everybody to the August NHS Northamptonshire CCG governing body meeting. This is a meeting that's being held in public, and thank you everybody for joining us. So I'd like to welcome everybody. I'd like to ask at this point whether there's anybody that is an on-call director who may need to disappear off the call.
Yes, Jo, it's me.
Okay, so if Sarah vanishes, that may well be the duty that she needs to attend to. Sarah, could I ask if you have any apologies?
I have apologies from Julie Curtis and Sam Turner.
Thank you. So are there any declarations of interest relating to items on the agenda that we've not previously recorded? Lucy, would you like to come in on the conversation at this point as well, please?
Apologies, it wasn't a declaration of interest or a conflict of interest. It was just for me to say apologies if I have to duck out. I have got the Department of Health and Social Care emailing me at the moment, so I may need to have a conversation with them at some point. So apologies, I'm not on call, but I may need to duck out.
We completely understand, and absolutely, if you disappear, we will very much understand that. So thank you for letting us know, much appreciated. So at this point, what we're going to do is to go through the minutes of the last meeting. We're going to go through for accuracy to start with, and then obviously for any matters arising that are not on the agenda today. I'm going to use the page numbers for the pack throughout this meeting, and would be grateful if other people could do likewise. I think it will just avoid confusion. So if we go through for accuracy first, if we start with page 4, page 5, page 6, page 7, 8, 9, 10, 11, page 12, page 13, and page 14. Is everybody happy that that is a true and accurate reflection of the meeting that took place last time? Thank you. So thank you, Sarah, for doing those. Very much appreciated. And are there any matters arising that are not on the agenda today? Okay, so the matters arising that we have from the last meeting, I'm not going to go through any that are green. We've got item 2148, which is an item for Stuart. Do you want to take this item now or later?
I'll take it now, Jo.
Yep, perfect.
As you see from the, we haven't brought the latest update to the governing body because we're due to all the current sort of issues going on, which we'll surely highlight to this meeting. We will bring that to the next governing body.
Okay, so would you like that action to be rolled over to the next governing body?
Please, Jo.
Yep, will do. The next action is yours, 2149.
That's due in October.
That's due in October, so we don't need to do that one yet. And that is it for the action log. So I've got an item from, oops, excuse me. Toby's asking if my camera is switched on. Can you see me at this point? No, okay.
I can see a few other shaking heads, Jo, so it might not just be me. Oh.
Okay.
I can see you, Toby, but not Jo.
Have I appeared?
There we go, Jo.
Fantastic. The IT trick of off and on again.
We can absolutely hear you, Jo, just to reassure you.
Okay, are you able to see me now at this point?
Yes.
Perfect. Thank you very much. Much appreciated. So the next item on the agenda is the Chair and Chief Exec's report, which obviously you will have read. Hopefully the combined report gives people the information they need. Is there anything, Toby, you would particularly like to draw the governing body's attention to?
Jo, there were just 3 things, if I may just briefly draw attention to, and more kind of updates rather than things that are in the report, but 3 things that don't appear elsewhere on today's agenda that I thought were relevant. The first is to say that the report does make reference to a couple of current governing body processes in terms of recruitment for lay roles, but I just wanted to draw board attention to the fact that as a system, we are also currently recruiting at the moment for the independent chair for the Northamptonshire Health and Care Partnership. So that really important role for our STP stroke ICS moving forward is currently live. If any of you through your networks are able to raise awareness of that, there's information on the Health and Care Partnership Board website. There's quite a bit of information that's getting put out through social media, Twitter and so on to raise awareness. And the application process is all through NHS Jobs. I'm pleased to say we've had a good level of interest already from quite a wide variety of people in different backgrounds, which is really encouraging, but there's still a week to run. The closing date for applications is Wednesday the 26th next week. So that was the first piece, Joe, just to raise awareness of. Second, just to acknowledge, and we will get a flavour for this as we go through the course of today's meeting in terms of things that are on the agenda. But I just wanted to acknowledge how incredibly hard I know everyone is working, both within the CCG, execs, management support, and our clinical leads as well. I'm really conscious, Joe, that from a corporate management team perspective, capacity-wise, we're currently very much missing Julie Curtis. It's great to have Julie Lemmy on the call with us today, but I know that's been an impact and putting pressure on Julie and others in the team. And also mindful as well that Lucy, because of her DPH role in some of our business intelligence support, etc., very much still COVID focused and outbreak focused, rightly so, but all of that is putting some very real pressure on the rest of the team at the moment, particularly at a time where we've been encouraging people to take annual leave through the summer as well. Which is a good thing, and I'm pleased to say people have been taking up our kind of ask to just take a bit of downtime, but put things like phase 3 letters into the mix in terms of planning, which we're currently focused on. And I just wanted people to acknowledge across the board table before we get into today's conversation, there were a lot of people working incredibly hard clinically, managerially as part of the organisation's effort. So that was my second point, Chair. Then the third point, just a bit of feedback and update on a couple of things regionally that I've started to get drawn into by our regional director, Dale Bywater. So as we come out of kind of the initial phase of incident response, I'm really pleased to say that the regional office of NHS England Improvement, which is headed up by our regional director, Dale Bywater, has responded to calls from a lot of us to get the 11 STP and ICS patches that make up the Midlands more involved directly in some of the regional leadership arrangements. So there are 2 new forums that are coming into existence that you'll hear me and others talk about more going forwards. The first of those is a Midlands Leadership team, which is Dale and his corporate management team from the regional office, together with the 11 STP exec leads from across the Midlands, which includes me for our patch in Northamptonshire. And the first meeting of that monthly group took place yesterday, and that's very much going to be about managing the day-to-day business and the business delivery across the region. And then the second forum, just briefly, Chair, is the Strategic Transformation and Recovery Group, the STAR Group, which has been established as a much broader grouping with a series of work streams, including one around the operating model for the region that David Nicholson's heading up for Dale, and I've been asked to get involved in that. I know Angela Hillary's involved in the recovery work stream that feeds into that STAR Group as well. So quite a bit of those new arrangements coming through. We'll get some of that written down and share it in terms of our Chief Exec's report for future months, and you'll hear us start to drop in bits of intelligence and briefing that come through those routes. But thought it was important, Joe, just to acknowledge those changes in our links with the region, which I think are really welcome about joint working locally and regionally. Thank you.
Absolutely, and I think as far as points to draw attention to, I would particularly like to say how welcome Bev, being the lay deputy chair, is, and very pleased to welcome her to that role, and obviously notify people that we are recruiting to the vacant audit role as well, and it's really important that we have strong lay representation on our board, and it is much appreciated. David, you wanted to come in with a comment?
Yes, on other issues, if people have moved on. I'm just picking up on 2 points on the national update, page 21. One is social prescribing link workers. HealthWatch is very supportive of social prescribing, but I think quite concerned. I'm not quite, don't wish to overstate it, but watching how this is developing and a very patchy implementation, and obviously it's very new. So we're keen to continue to be involved with that. Speaking personally, I'm looking at the numbers of people being recruited and reflecting on where they are coming from, what is their background, what is their brief, what is their job description, what skills are expected, and how will it work. I have to say that this whole development, good as and welcome as it is, I'm not convinced that there's been sufficient thinking through about the skill set required for these staff. This is a very complex role that is required. Coming from a social work background, I've seen so many times people saying, oh, well, if you've got a good heart, that's good enough. And frankly, this is a complex community role involving a lot of networking, as well as the individual connections. And I think more work needs to go in about the skill set that is required, but also the professional accountability. I'm all for barefoot doctors and so forth. There's a lot that is going there, but people are very involved in people's lives. So just flagging up that I think there are some questions about the skill sets and professional accountability of this cohort of very diverse people that I think will need more thinking. And I'm basing that also on comments coming from some of those who've been supervising this group of workforce. I'm not necessarily expecting a response. I'm just flagging up that it's an issue that needs to be thought about. I've got one other comment. Shall I just go straight on and make the other one a separate issue?
Yes, please do.
On the diabetes, I suppose I should declare an interest that I'm following one of these courses as a somebody involved, and a mixed experience. I have to say, of course, COVID is a strange time. It's all being done by Zoom, but perhaps there are other places to give the feedback. But I'm just declaring my interest in that as a personal recipient. Not a mystery shopper. It's all transparent.
Thank you, and we should never forget we are all patients, many of us within the county, and we all have those dual roles. So yes, we are but human, and we are frail, like all of our patients. Thank you. Ange, do you want to come in?
Yeah, I just wanted to just bring people, make them aware. It's already in Toby's paper, but I think at the time of writing this, we hadn't received notification that we'd been successful in securing monies for pulse oximeters. So we have been doing lots of work and training with care homes around baseline observations, but we've been successful, and this is really significant for primary care. So we are working closely with our colleagues over at the council and with my colleagues in primary care, because obviously these are really important pieces of equipment. Apart from being expensive, they give a really good baseline for staff to actually understand when residents are deteriorating. So it is really successful for Northamptonshire. So it's very new. We've only just been given the notification, but I just wanted to let people know, because we were only one of 2 bids that was successful in the Midlands region. So I think that's really good for us, and actually detecting deteriorating residents and keeping people out of hospital. So I just wanted to add to what Toby's said already. Thanks, Jo.
Thank you, and congratulations to everybody who's been involved with the bid. Everything that we can bring into Northamptonshire for the benefit of our population is very much valued. Thank you. Philip.
I did have one thing. It's 2 things now. The first question is to Toby, and that is he mentioned Angela Hillary and her input into the regional group, whether there's any specific primary care input into this regional planning group. And the second question now goes to Ange, if that's okay, and that is with the district nurses checking oxygen saturation levels on patients, it is an extra workload, of course, for primary care, because we often have to override the protocols that they work to. And I just wondered, in terms of the instruction to nursing homes, whether that's been fully factored in.
So if I can respond, Jo, just to let you know, Philip, that's something that we've looked at, because the last thing I want to do is give people equipment, and 1, they don't know what to do with it, or 2, it undermines what other people are doing. So we haven't received them yet, but what we are going to do through quality and safety, working jointly with NAS as well, because really we're looking at nursing homes to begin with, is to make sure that the training we give them is fit for purpose and they understand the boundaries. I don't want boundaries being blurred, because the most important thing is we need to make sure we're all doing the same thing, and monitor in the same way. So Philip, I'll keep you abreast of it every step of the way. We've only just had the notification, so we will work closely with primary care, also with NHFT as well, and also with NAS. So I just wanted to let people know, but I'll work very closely. And if you think at any point it's undermining what's happening within primary care, please do let me know.
Thank you. And then I think, Toby, the other question was for you.
Yeah, thank you, Joe. Thanks for the question, Philip. So of those two groups I mentioned, the group that's called the STAR group, which is the time-limited transformation and recovery group, basically how do we reset and restore things, that group does have a really wide range of membership of people that have been identified because of their interest or expertise in different things. So I know that does include clinical and managerial input. I've asked for a full list of the members of all the different work streams, and when I've got that, I'll share that. But I do know from the first of the meetings I was involved with, there was a GP lead from Derbyshire in the room who was leading on some of the health inequalities work. I also know that the regional medical director and nursing director are involved. So that one's not a representative group. It's people who've been picked for their interest in different areas, but there is definitely some GP and primary care input where that's been drawn into particular areas. The other of the two groups, the Midlands Leadership Team group, has Dale's regional medical director and regional nursing director, but the other 11 people who have been invited into that are people who hold those STP exec lead roles. And I don't think from memory that any, I think they're almost all entirely either CCG accountable officers. There's one acute trust chief executive, and I think there's two individuals who are almost independent roles that don't also hold an office position. But those ones are very much whoever it happens to be for your county, for your STP area. So I hope that helps. I will, Joe, circulate round to people both the terms of reference for those groups and also the membership as well, once I've got a full breakdown of those, so people can see who's connected into those different things.
Thank you. I think the key thing with those is actually learning from across the region, which I think is an opportunity that is going to benefit all of us. So I think that connectivity is really helpful, and obviously we'll share that information as it comes through. Thank you. So we don't have any questions from the public for this meeting. The next item on the agenda is item 8, which is the COVID-19 response, and this is your item, Lucy. Is there anything you particularly want to bring our attention to? Obviously, we've got quite a lot of information, much of which is in the public domain, which is fantastic to see. Tell us what else we need to know.
Okay, thank you, Chair. So as you quite rightly say, we've been producing a weekly surveillance report now for a number of weeks, which is available on the Northamptonshire County Council website. So I'd encourage people to go there for all of the latest information. It provides not only the weekly surveillance report, but it also does provide up-to-date information about all the testing sites across the county. So again, it's a key resource for the public. The latest surveillance report, which includes data up to the 9th of August, obviously reinforces the fact that we have still got an increasing incidence of COVID locally, and in particular Northampton, Corby, Kettering and Wellingborough are being affected. So we understand obviously that there is a significant outbreak at Greencore in Northampton, and that is in part driving the increased incidence that we're seeing in the report, or certainly we'll see in next week's report that includes data for that test period. But what I do want to take the opportunity to stress is it is not the root cause of all of the increase locally, and we're still encouraging people to get tested if they have any concerns at all that they've been exposed to COVID-19 or indeed are experiencing any symptoms, and they should be self-isolating from the point at which they develop symptoms and until they get their test results. If they are positive, the requirement still remains that they self-isolate for 10 days, and any household contact would be required to self-isolate for 14 days. It would only be on receipt of a negative test if you were felt to be a case that you would be able to come out of isolation. Even if you are a household contact with a positive case, you still do need to complete the 14 days self-isolation. So apologies for repeating those messages, but they're really key at the moment. So people will also be aware of the fact that we have been requesting residents take additional action further to the release of a lot of lockdown restrictions at a national level. So locally, we're still asking people to maintain the 2-metre distance from others at all times and to limit contact with anyone outside of your household or support bubble. If indeed you must meet people outside of your immediate household or support bubble, that we would encourage people to do so outdoors. And again, if they're unable to do that, to use a face covering if that meeting must be indoors. We're encouraging people not to be sharing items outside of your household or bubble. And obviously, if you're having to share transport and things like that, to make sure that you use a face covering, whether that be on public transport or during car sharing with others. Again, the basics of hand washing and hand hygiene are key here, and we're encouraging people to continue to maintain good hand hygiene, washing their hands frequently, particularly when they come in from being outside or anywhere where they may have had interaction with anybody else. And of course, if you're able to continue to work from home, but obviously that's got to be balanced with what is business critical, where services are now reopening. So at the moment, we have got a statistically significantly higher rate of COVID as a county compared to the England average. And within Northamptonshire, specifically Northampton and Kettering, remain statistically significantly high. We know that this is the working age adults, both male and female, that have been primarily affected. We do still have a number of cases, small numbers in care homes. So at the moment, we've currently got 11 outbreaks in care homes, but they are all very small numbers, and therefore being managed internally with support with our community infection prevention and control team. As you know, what is of more concern has been the workplace outbreaks, where we're seeing an increase, obviously, in the number of those as people return to work, but also we've clearly got one of the most significant in the country in Northamptonshire at the moment. What I can tell you about that is that it appeared over a space of about 10 days, and Public Health England were involved in managing that from the outset. What seems to obviously have escalated that is Greencore, who is the organisation involved, took a very responsible decision when they had a number of cases identified in their workforce to undertake private testing. And that private testing obviously meant that a significant number of individuals were tested across a 3-day period, which resulted in 287 employees being identified as COVID positive. So that number is slightly lower than previously reported numbers, because we've identified that there were some duplicate tests of those who went through a national portal at the beginning of the pandemic outbreak and those that went through that private testing. Those employees are primarily residing in Northampton, but there are also a number in Wellingborough. And therefore, again, we just ask people to remain vigilant around the development of symptoms of COVID-19 and to maintain all of the recommended actions as outlined at the beginning of the discussion. And we would obviously encourage people as well to provide any information that they do feel is pertinent from a point of view of compliance. We're working really closely with our environmental health officers around the nighttime economy and also compliance within our work settings to ensure that they have all of the support they need, so that where those higher risk settings do exist, we're able to provide advice and information to help mitigate any risks that exist. So I will stop at that point. What I am pleased to say is that we've seen a significant drop, I should say, in our NHS service demand from a point of view of COVID-19. But otherwise, people are managing to self-care when it comes to the current positivity rate. So I will actually stop there and see if there's any questions.
Thank you very much, Lucy. And albeit we have heard it many, many times, there are many members of the general public who are still confused about the advice. It is difficult to follow, but it is really, really important. So thank you very much for reiterating that for us. David has asked a question about places of worship. I do know the answer to this question, but I'm going to let Lucy answer the question on this one.
So yes, there's specific national guidance on places of worship, which actually have been updated in recent days with regards to actually singing as well within places of worship. So again, the best point for guidance at a national level, because no restrictions have been placed locally on places of worship, is still the national website.
Yeah, David, anything else you want to say on that?
Yeah, thank you very much. I was aware of that. The issues are the local consequences, particularly some of the guidance which you just referred to about meetings. I know of 1 or 2 places that were expecting that they would open following national guidelines in September, but in the light of the local developments are thinking of not opening Is there anything specific around that we would want to say? I guess it's not about places of worship, but it's places of gathering.
Hi. So no, at the moment, what we have done is make sure that there are specific restrictions in place that are pertinent to the particular wards and or the particular age groups that have been impacted. At the moment, there is nothing to suggest from our intelligence locally that that would need to include places of worship at this point. Obviously, things change on a day-to-day basis, and should we find that there's any correlation, or indeed should a national decision be made off the back of the increasing incidents around local restriction measures, then we would of course keep people involved. But at the moment, particularly in relation to that, it is national guidance.
Thank you. So Ange and then Toby after that.
Hi, yeah, Joe, thank you. I'm sure my governing body members have heard me talking about St Andrews, and we had a significant outbreak in St Andrews around about April. But I'm really pleased to tell you we had a meeting with St Andrews this morning, and it's been 106 days since they've had a patient positive with COVID. They've worked exceptionally hard, and we've been keeping track with NHS England, and they have been really humble in accepting lots of support, advice and guidance, and it's really paid off. They have a very big workforce, and I think they need to be commended for keeping hold on it. So I just wanted to bring that to the attention of the governing body. So my partners in public health and in the council and in NHS England have really supported us to get them back on track. So I just wanted to bring that to your attention, Joe, because they've worked incredibly hard, St Andrews. Thank you.
Absolutely, thank you, and thanks to everybody that has managed to reduce the incidence in all sorts of patches across the county as well. Toby.
Thank you, Chair. Just wanted to pick up on a link. Lucy rightly referenced the outbreak position and Green Corps, and most board members will be aware that Green Corps' one of their core kind of bases is right in Moulton Park, next to the main CCG's offices as well at Francis Crick House. And I just wanted to reassure board members that we have, as you would expect, reviewed kind of our arrangements internally in order to assure ourselves that we continue to be confident that they are COVID secure, and we are confident that we are doing everything that we should appropriately in order to manage risk. And I would emphasise manage risk, because this is a situation now going forward that is about management of risk rather than elimination of that. But we are confident that we are appropriately managing that within the building with those staff who are still working from there. And just again, a reminder for most board members who want to be in and around Francis Crick for some time, the vast majority of our staff are continuing to work from home at the moment, although we are in the process of bringing a smaller number, 15 to 20, back in to work more intensively on the phase 3 planning work that Sarah will talk about a little bit later in one of the subsequent items. But I just wanted to reassure the board that we were obviously aware of that connection and that physical proximity, and had reviewed appropriately in light of that. I don't know, Lucy, if you want to add anything to that, but I thought it was worth drawing to board's attention. Thank you.
Chair, may I add actually?
Please do.
Toby raises a good point. So just for people's awareness, when they do see some of the mapping associated with the outbreak, because it was a privately commissioned testing service, all of the tests were allocated to Green Corps' address, and therefore it looks like there is a significant surge in cases in what's actually called Parklands ward, but it is actually the location of the premises for Green Corps. So just so people are aware of that, from a national perspective, it looks a little odd. Locally, we do have the data about where all of these cases live, and that has been mapped. But at a national level, it's quite likely to translate to the work address because of the way the testing was undertaken.
Thank you. That's really helpful, and I think helpful to know from the point of view of the local population as to where the actual raised incidence is. So thank you. Andrew.
Hi, Lucy, I don't intend to put you on the spot to speculate on further lockdown activity, but I guess the question is, do you have a sense of timescale for any decisions if we were to take further mitigations beyond the current advice to residents?
Yep, so PHE did a piece of work for us yesterday to worked in fact late into the early hours this morning, because there's this Chief Medical Officer Silver meeting today to disaggregate the data, so to be able to extract those cases that are related to the outbreak and look at the underlying incidents in Northampton and Wellingborough in particular, because that's where the residents reside. And Those two rates actually are not a cause for concern in and of themselves once you take out green core, but obviously our cumulative incidence rate now puts us as the highest increase area in the country, because we had such a focused testing regime, and because the proportion of those employees that tested positive is significantly higher than you would normally see in an average population. So although we're able to demonstrate that our underlying community incidence isn't terribly high, clearly the government would still be seeking assurance and may feel that it's appropriate to take additional steps due to the number involved with a particular setting. And green core, as we've said before, is not unique in this. There are other workplace settings currently and have been previously that have been affected by outbreaks. So I do want to stress that this is not unique to green core, but it's certainly something that there may be a view that we need to be doing more of us, and therefore additional support may be offered. Those meetings happen to all intents and purposes on a day-to-day basis, but we would get information in the next 24 to 48 hours if we felt that that was likely to escalate.
Thank you, and thank you for your very detailed response, Lucy. It's really appreciated, and all the input from your entire team as well. Thank you. The next item on the agenda is item 9, which is the third phase of the NHS response. Sarah, over to you. What would you like to tell us in particular?
Thank you, Jo. I'll just run through probably some of the key headlines from the paper, but probably focus more on the update since the paper's been written as to the current activity. So the phase 3 letter from Simon Stevens and Amanda Pritchard is attached to the papers that have been provided to you, and we're now, in essence, informs both deliverables, but also forms the structure for planning for the rest of 2021. There is still some information that we don't have, but this letter, in essence, sets us a number of now deliverables and planning targets for the rest of this year. And hence forms really the planning framework for the NHS as well for the next 6 months. 3 priority areas from the letter: so accelerating activity back to near normal levels, preparation for winter, alongside possibly local and national spikes for COVID, and also a real focus on support for our staff, action on inequalities and prevention are the key themes that kind of run through all areas within the letter. I think just in terms of the milestones here, there are 2 planning milestones that the letter sets out for us. One is a draft system plan by the 1st of September, and the second a final plan by the 21st of September. That also includes, not by the second deadline, a draft people plan for the system as well. So we will be required to send in both a system plan and a people plan by the 21st of September as a Northamptonshire system. There are also a number of deadlines and returns due from the system prior to the 1st of September. Some significant ones around activity and money within mental health, but others as well. So just so people get a flavour of the activity that is currently ongoing. There are also within the letter some deliverables in the very near future. So for instance, we are required by the 1st of September to stand back up CHC assessments, and also to plan to eliminate the backlogs. And then there are also some things which feature as planning targets but have deliverable deadlines in the immediate future. So elective services standing back up to 70, 80, 90% over August, September and October, and various other examples within the letter. I'll just then, Jo, take a couple of minutes to talk about the system response and then happy to take questions. So since the paper was written roughly a week ago, we have now convened a number of forums across the system in terms of mobilising the work required in the phase 3 letter. We have designated CCG leads to support all of the workstream areas, and those leads are now meeting on a daily basis at 8:30, and will continue to do so probably until submission of the final plan on the 21st. We also have an executive planning group that is now meeting 3 times a week, and also a daily technical group that supports the technical architecture underneath this plan. And all of that is supported by finance colleagues and workforce colleagues in terms of trying to triangulate some of the planning assumptions that we're using. So really just to set out the significant both volume of work and pace of work that's required over the next 2 weeks to the first deadline. But probably then just finally to talk about some of the risks here. So we know, as Toby said at the beginning, we have an awful lot of staff doing an awful lot of work. We also have a number of people on pre-agreed annual leave over the summer period. So we are stretching resources over the next couple of weeks. And that is giving us some challenges in terms of specific areas, all of which we're working to mitigate. It's just worth us recognising that. And also, I think, given the deadlines, probably some things that in an ideal world we would do before submission of a draft plan, which we'll probably have to do between draft and final planning. So some of the triangulation work and some of the impact assessment work probably will take place between draft and final instead of before initial draft planning. Hopefully that gives a flavour of both summary of the letter and also actions taken since. And happy to take any questions on any of that.
Thank you, Sarah. And I think we all recognise the enormous amount of work that's being asked for and how important it is for us to get this right. Philip.
Yes, I asked at the last governing body meeting about planning for demand on the day and access to emergency care. And I now see that we've got 111 first to plan for as well. And with Julie away, I'm just wondering what the work stream and what the planning for that, what responsibility is being taken for that.
Sarah, do you want to come in on that one?
So in terms of leadership of that work stream, Philip, we've got Julie Lemmy, I think, on the call as Julie Curtis's deputy, who will be holding on to some of the primary care impacts. We've got Jane Taylor leading some of the urgent care sections, supported by all of the director team in terms of CMT. I am chairing the daily call that we talked about, and also the exec call that we talked about. So routes of escalation provided for Julie and for Jane in terms of holding on to that workload.
Thank you. Andrew.
Hi, thank you. Note the very tight timescales and the hard work involved. I think added complexity is the lack of the financial framework being agreed until after the plan needs to be submitted, which I guess gives the execs a high level of ambiguity. Given that, are we comfortable in the risk sharing agreement across the system? Because I think that's imperative to ensure that it's in place if we're entering into a plan with a bit of our hands tied behind the back by having no agreed financial framework, which I assume is the same for all system partners.
Sarah, you want to respond? Or do you want to respond, Stuart?
I can see Stuart with his hand up. So I'll let
Stuart put his hand up. Stuart, it's your question.
Yeah. So the easiest, most probably the easiest way to put this, the new financial regime will require the system to balance in totality. So we are, without a shadow of doubt, sharing in that shape or form. It's not an individual target, although we have individual targets. The system as a whole has to balance financially. That is the requirement. So if one organisation was to go into a sort of deficit position, the others have to make it up. And that's the way it will be looked at by the region and national team. So by definition, we are sharing to a certain extent.
Thank you. Toby.
Toby, you're on mute.
Sorry, apologies. Mine was on a different point, so I don't know if Sarah was going to build on what Stuart was just saying or whether yours, Sarah, is on a different topic as well.
Mine is a governance and approvals, Toby.
Okay, in which case I'll keep going.
On.
Yeah, okay. So I just wanted to come back to Sarah's description of how we're approaching this in terms of the groups and the leads involved in things. I just wanted to point out as well that Joe helpfully went through with us last week to make sure that we buddied up all of our clinical and GP commissioning leads against all of the different service areas that are set out within the letter. And the teams of people that we've got working and then meeting daily, I've got a very clear expectation that they should be reaching out to their respective GP and commissioning leads to involve them in the work, make sure that we've got the Asses, the Emmas, and the Nathans and so on plugged into the right areas of work. So that is underway as part of this. And for me, that's part of the mitigation of the timelines here that are so tight, they're not going to allow us to easily bring things through in some of the other forums that we might. We need to really make sure we've got the sense check between the clinical and the managerial leads, whether it's on mental health or on LD or on cancer. So those things are tight. That's what I wanted to draw attention to, Joe. Thank you.
Thank you. Sarah, did you want to come back in?
Yes, if possible, Joe. I've just got a final point on governance and approval. So I've just checked that no one else has got any other questions on the content of the paper. No. Okay, it's really just to ask, so question for governing body in terms of approvals of the submission of the plan. We would normally look to take it through a subcommittee and or governing body for its final approval. But just in terms of timelines, we don't have any committees ideally placed within the timelines, given how much work there is to do and how soon the content will be ready for easy approval. So myself, Stuart and Neil Boughton have all had a discussion and would like to ask governing body to delegate responsibility for approval of the plan to CMT to enable us to get it submitted, approved by the 21st. So it was just a quick discussion about that, and then ideally a governing body approval for that as the assurance mechanism, please.
Okay, so prior to typing anything in the chat bar from that point of view, does anybody have any comments or questions about delegating approval of our response to the corporate management team? Yep, Toby.
I think that's appropriate and necessary, particularly for the 1st of September submission. I think that between the 1st and the 21st and final, we do have a governing body meeting, I think, on the 15th of September. And I think it's important that we use that meeting in particular to focus on any aspects of this letter that we are proposing submitting a plan that doesn't answer in full the ask that's set out nationally in terms of expectation. So that's my way of saying there's a heck of a lot in this letter, and at the moment we don't know locally whether that is all doable all at the same time, and particularly how vulnerable delivery would be to different scenarios in terms of activity, or in terms of COVID, or in terms of flu and routine winter activity. So I think for that reason, Joe, it's important. I'm supportive of Sarah's suggestion. I don't see, frankly, an alternative being here in the 1st. We will make sure what goes in is a system submission, so it would need kind of effectively exec sign off from a system point of view. But I think between there and the 21st, we do need to use some of that governing body time to be able to pick out any particular areas where we are struggling with confidence to be able to say that we can deliver against that national ask.
Thank you, and very helpful this morning from our lay members mentioning that the Strategy and Planning Committee was also supportive of this approach, which I think is helpful. So for those of you that are voting members, if you could use the word support if you support this. Neil, just before we vote, Neil, did you want to come in there?
If I may, Joan, just for the purpose of the recording, if I could, Toby quite rightly mentions we have governing body time in September, but it's for the purpose of recording. It's not a public governing body time, it's governing body thinking time. So it's just for the purpose of the recording and for members of the public that would be viewing this. It's not a public governing body meeting. That next one is October.
Thank you. So the formal process is to delegate that, albeit there will be further conversation. So if you do support that, if you could put the word support, that would be really helpful. Thank you, Neil. Thank you. So I think we definitely have enough votes there. We are quorate, and thank you very much. So the next item on the agenda is item 10, which is the integrated care system. This is mentioned on the agenda as an item for approval, although it is, I would like to amend that to an item for recommendation. There are not actually items to approve on this, so this one will be a question of whether we recommend it, and obviously need to go through that in some detail. So, Ali, is there anything you would particularly like to draw our attention to on this paper?
Thank you, Chair. Just a couple of points. This is a paper that's navigating its way through provider and commissioner boards and governing bodies across the whole system. So it's a similar paper asking with a similar ask across all the boards. So that's an important point. It's been through the partnership board, the Northamptonshire Health and Care Partnership Board in July, and it's been agreed in principle in terms of the architecture, the integrated governance and the approach, and it's providing clarity on the timeline and the roadmap to an aspiring ICS. And then the next phase will be moving towards a thriving ICS. So the intention is to bring everybody and the governing body up to speed with where we're at with the development programme. It also defines the architecture of the integrated care system programme as we move forward. And there are 2 points that are particularly relevant for the governing body, is that the intention is that we strengthen clinical and professional leadership through the whole architecture as we drive the agenda forward. And also is a descriptor of the locality function as part of your integrated care system. And there is a great opportunity for us to move that forward at pace, particularly with our locality chairs. So I think that's all I wanted to bring through. Happy to take questions and then move forward to the recommendations.
Any questions or comments for Ali on the ICS paper? A stunned silence. Bev.
Thanks, Jo. I had a really useful opportunity this morning to talk to Ali about the infrastructure section and just clarified 1 or 2 queries that I'd got, so I won't repeat them here. I think from a lay perspective, I'm interested in how this is populated. Ali and I talked about that to make sure there is proper representation, not only clinically from an exec point of view, but from a lay perspective as well. And then obviously what the paper doesn't do, and you wouldn't expect it to because it's a system paper, how then our own governance infrastructure interfaces with this. And I guess that's probably true of every component part and every piece of the system. So it might be a very complicated diagram, but I certainly want to know from our side on the CCG how each of our committee structures interface with and where the necessary flows are. Because you're seeing this in isolation, there is another governance structure over here for the CCG that needs to interface with that. So it's not a question necessarily for answering now, but I think it's definitely a diagram that we need sight of, which shows where the connectivity is.
Thank you. Ali, did you want to respond, or are you happy just to take that recommendation?
Completely agree, and I think that's part of the reason why the paper is going through all the boards formally as well, because it will be a hardwiring not just into our governance but into individual governance across each of the providers and their architecture. So yes, I think we've got to be clear where we are going to hold this at subcommittee level. If there is a conversation as well, we talk potentially strategy and planning. So where is there a subcommittee conversation about it, as well as a governing body and as well as a clinical conversation? But that's probably a question for us to take as a consequence of this discussion.
Thank you, Ali. Philip.
So I take note of what Ali said around clinical involvement, but what concerned me when I saw this paper was it was a recipe for more of the same, and that there's no facility within it for it for us to have an organisation which is clinically led, in which we can get effective change of services and provision of services for our patients, which can be driven through the system and approved. And so a real concern, we can think of real examples of clinical proposals which have been put forward and developed but not approved for various reasons. There needs to be an element of risk in any development of any service and any change of service, and this appears to be yet another fail-safe, do-nothing structure which I think we need to look closely at before we approve.
Ali, would you like me to respond to that one?
Thank you.
So obviously, as part of my work with clinical leaders across the system, that group has been intimately involved, and that group does include primary care representation as well, making sure that there is the right clinical infrastructure, both in quality, transformation, and also looking at the finance side of things as well. It is really important that that clinical voice is heard throughout the system, not just from doctors, from nurses, allied health professionals as well, and across the system, speaking as senior clinicians rather than necessarily organisation specific. And essentially the group is dedicating itself to make sure that the clinical support and voice within those new committees is quite different to anything that we've noted before, and clinicians are not put in separate committees that are absolutely embedded within the work that is taking place at the moment. So that is a key area of action, and you're absolutely right, we don't want to do things exactly as we've done previously. Thank you. The next person on my list is Lucy.
Hi, it's actually two quick questions. So one is, obviously we're not alone in wanting to, having to move to an ICS. So I'm just wondering if there's anywhere that we're looking to for best practice. And I know it's challenging because I don't think anyone's got this completely cracked, but is there somewhere that we could take lessons from perhaps and learn about what has and hasn't worked? And the second question was, obviously I noticed one of the pillars is population health, that we've talked about before, and it also alludes to Bev's question, is the Health and Wellbeing Board has the statutory responsibility around reducing inequalities as well. So how do we make sure that system governance architecture plays in at the right point as well? Because I know that's been an ongoing challenge about the NHCP board, so the predecessor to the ICS work.
I'm not sure. Do you want to start that one?
I'm happy to take the first question, maybe pass the second question to Toby, possibly around the Health and Wellbeing Board. So Lucy, there's monthly meetings with all the SCP leads across the Midlands and nationally as well. So we're sharing good practice. I've just come off a call this morning, and there's been sharing of information with respect to Nottingham, who have moved into a thriving ICS, and how their functions and how their architecture, lessons learned. So there's close connectivity between the NHCP transformation team and best practice. What we're trying to do is utilise that and then adapt it for the needs and the strengths within Northamptonshire. So I can assure you that that is forming, and the partnership board and its discussions. And then the Health and Wellbeing Board conversation. Toby, do you want to come in on that?
Yeah, thanks, Ali. And I'll partly respond to that and partly just broaden it back a bit actually to Philip's point as well, because I think in a strange way, I think both Philip and Lucy's points in my head are linked, because they're both about things where we don't necessarily have all the answers at the moment. And so some of this is going to have to be, how do we all work together in order to put things in place and make this ICS model work for Northamptonshire? Because we can look at examples of other parts of the country and other parts of the region, but they are all different. Specifically on the health and wellbeing point, clearly that's a statutory responsibility that sits with local authorities. We will have 2 upper tier local authorities. There have been conversations already started with the shadow leads for those areas. We're starting to see some of those key joint appointments being made now as well, in terms of the chief executive appointments. So I'm optimistic that before too long we'll be able to get into closing some of those things down. But that needs to be done jointly, and to work out where the balance of those functions then sits, both from a unitary point of view and with some of the county-wide work. One thing Anna Earnshaw, who's been appointed into one of those chief exec roles, has said repeatedly over recent months is that senior political leaders within the districts, boroughs and the unitary emerging arrangements are all absolutely supportive and behind the health and care integration piece. So I think this is about how do we do it and make it work better than we've had in the past, rather than any impediment to that. And I think to Philip's point, to be fair, it's in the same sort of space. Philip, I'd encourage you and the locality leads and others to help us to shape this in a way that doesn't bring about the kind of anxiety, the concern that you described, that we end up just creating something that's more of the same. Those of us who've got, and all of us have a role in shaping this, want this, need this to be different for people locally and for our local population and patients. So we're going to have a conversation. I think you invited myself and I think Ali to drop into the locality meetings next week that you're all running, and really keen to work out how do we shape that with PCNs, localities, federations, to make sure we don't just end up recreating something that feels like things we've had in the past. So I suppose there's an offer, but there's also an ask as well for you and others to help us to shape all of that. Thank you, Jo.
Thank you. And I think it is how we work as part of a wider health and care system. This is not something being done unto us. This is something where we all have the opportunity to shape this. Just for those of you that have been commenting on the interference, I have been gently muting people who have not muted themselves. So apologies if you feel that I'm interfering, just trying to improve the sound quality. Darren.
Yeah, actually, Toby stole my thunder, but I think just to reassure the governing body that the locality chairs had a really useful meeting with Toby and with Ali and yourself, Jo, over the last 2 weeks to really look at how we drive the ICS from a bottom-up approach, from a place-based locality approach. And I think it, as we all know, it will all depend on relationships and starting those conversations earlier with that type of multi-professional alliance type providers is really going to help us be set up for April. And I think, you know, and it's great having Toby as the ICS lead coming, because I think primary care still has a lot of questions, and the difficulty with the outcomes-based contracts, and it is mind-blowing. But what it needs to boil down to is, what does it mean to me as a practicing frontline clinician? On, you know, all of the stuff that we've been talking about is very high level. So I think to get to that detail next week at the locality meetings will be really helpful.
Thank you. And I think the locality basis is absolutely right for this. You know, this is the population that we're caring for. So I'm really pleased that the conversation is taking place in that forum. That's extremely helpful. So obviously the recommendation is at the end of the paper. Ali, do you want to just take us through that recommendation before we give our views on that?
Thank you, Chair. So the recommendation is for an ask for support for the traveller and the development of the ICS programme as defined in the paper, and also for a commitment to the integrated governance and the subcommittee architecture that's outlined within the paper. The rest of the recommendations are just for note. So it's those two key recommendations.
Any questions about the specific recommendations from anybody? Okay, so you know the drill. Oh, hang on, Philip, do you want to come in at the last minute? Over to you, Philip.
Yeah, no, we did put some caveats around what is proposed, and I'm just wondering how those were going to be shared with our partnership organisation.
So which caveats are the ones that you particularly would like us to consider within our recommendation?
There was the strengthening of the clinical advice and the pathways that follows. There was something about public health, which Lucy mentioned. I can't, her words are better than mine. And there is the strengthening of the locality bottom-up approach to provision.
So more than happy to note those elements. I don't think that they stop us from recommending a direction of travel, and certainly we will make sure that those are noted within the minutes of the meeting. Happy to do that. Ali, any comments about those particular elements that Philip's just mentioned?
It's just to reinforce that the locality engagement and development work with the localities, we will commit to doing that as from next week. The clinical leadership element is a dominant part of the discussion, and I think we need to bring the locality leads closer to that, Jo, as well. And I think we've responded to Lucy's discussion. I do think the point around the Health and Wellbeing Board, we still need to work that through with the Partnership Board, but that's not just for this governing body, that's for the Partnership Board and the Health and Wellbeing Board to work that through.
Thank you. Toby, you're on mute.
I've been far too successful at double muting myself now to avoid any feedback that you can't hear me. It was just a thought about how we take these sorts of things forwards, and a practical suggestion, Ali. You mentioned earlier on, I think, that some of the other governing boards locally are taking this paper through their own internal discussions, and some, like NHFT, I think, have invited you to join them. I'm pretty certain that they will have similar discussions and identify their own issues that they feel need to be worked through as we take this work forwards. So I think it'd be really helpful if you could kind of almost start a running list here of some of the things that Philip's just summarised from our conversation, and then adding that into some of the things that come out of NHFT and the two acutes, so we could bring back something into the partnership, but also that we can share with our own boards to say, when this is being discussed in the round, these are the kind of issues and challenges that different parts of the system feel need to be addressed as we take this work forward.
Happy to do that, Toby, on the case already with it. Thank you.
Perfect. Thank you. So if people could put the word recommend, because it is more recommendation than approval, both words are used. So if you're happy to put that, if you could put recommend into the chat bar, that would be really helpful. Extra points if you spell it properly. Thank you. Thank you very much, everybody. Much appreciated. I appreciate this is a slightly odd way of raising your hand, but it is something that is necessary given the technology that we have. So the next item on the agenda is the public health update. Appreciating this is a slightly sensitive time from a whole wider public health point of view. Thank you as ever, Lucy, for providing us with this information. The summaries are always useful. Is there anything you would like to tell us at this point that isn't politically sensitive?
So no, and thank you for noting it is obviously a slightly shorter update than normal. Some may be relieved because sometimes it's quite busy. But obviously two of the key issues I think here are, one, a recognition that local government reform continues to happen in the background. So obviously that is the same for public health as it is for all of the other borough and district and county council services. So it continues to be challenging from a point of view of being able to resource those plans. But obviously also there are discussions and decisions yet to be made about the future shape of public health. What we do know is there is agreement that there will be a single director of public health across the two unitary authorities, and there is a desire to maintain a single business intelligence function with NHS partners, because that has provided such value to the COVID pandemic response. So those are two key decisions which have been made, but the rest of the team is still yet to be shaped. One of the key things that's happening over the next couple of months, though, that significantly obviously impacts on primary care is the local pharmaceutical needs assessment. So this is one of the statutory functions of public health, and it has to be updated every 2 years. So at the moment we have done the same as we did last year, went out to get 3 quotations for this work to be undertaken by a company that are expert in doing so. And it is a process whereby a review of the current need for pharmaceutical services is undertaken in the local community, and then a report is triangulated against the services that are currently in place, so that we can identify any gaps that may exist in the pharmaceutical support services across the county. Obviously, a lot of this requires engagement with both those pharmaceutical service providers and also the general public. And so the County Council's consultation hub is being used to help provide an opportunity for people to express their views on the access and efficacy of those services locally. So I encourage people to complete that, and would ask that HealthWatch also, if they're able to, distribute that throughout their networks as well, to encourage both those providers and the public who use those services to provide feedback to help us shape what pharmaceutical provision will be put in place going forward.
Thank you. Any comments or questions for Lucy, or comments on the public health update? Chris.
Hi there. Given that there has been a national announcement 2.5 hours ago at the time of recording, I I'm not expecting any formal response, but I just wonder whether in due course you can update the governing body on the impacts of such a reorganisation.
Yep, so if I come back, so I think you are referring to the reorganisation of Public Health England, not the local public health team. So yes, I understand there has been a keynote speech, which I have not seen the detail of yet, having been in meetings today, which will outline how Public Health England will be reorganised to merge or certainly align better with the national contact tracing services. So absolutely we'll come back when I have more detail on that to provide a summary both of what that will look and feel like at a national and regional level, but also what impact it may have locally.
Thank you, Lucy. Toby, do you want to come in on that one? No, perfect. Thank you. So any other questions for Lucy with regard to the public health update? We seem to talk a lot about public health at the moment, quite rightly. It is really, really important and is really interesting to hear. Oh, that's fine. So the next item on the agenda is the finance report. No surprises that that is Stuart. Stuart, over to you. Tell us what we need to know.
Thank you, Jo. I'll assume the paper is read and I'll bring out some highlights. Obviously, we are now moving into what, as correctly, the third phase of the sort of COVID-19 and what I call a third phase of financial regime just for this year. And Andrew obviously has alluded to, we don't actually have the final guidance for the finance elements of it yet, but I'll try to bring out what I know. Blocks will remain for NHS contracts towards the end of the year. So up to month 6, everything will continue as is, and we'll go in from month 6, except with the exception of CHC, which goes live on the 1st of September, so some slight changes. The system will have a specific fixed COVID-19 allocation, which we haven't been notified how much that would be yet, or the allocation that the CCG would get on behalf of the system for the rest of the year. What I can update on at the moment is this is a month 3 report, which highlighted we did have an overspend of 2.7 million. We have received all the funding, 100% funding. Retrospective was at the moment is how we claim that money back up to that point. So we are in a break-even position at that point, up to month 3. Everything we claimed has been refunded, so we are break-even. We're in the process of claiming month 4. We are likely to get an answer next week, which I have promised I will email Andrew Hammond an update on, because there's a bit of primary care spend in that from a primary care committee. So the thing most probably worth noting is some of the areas are underspending, like CHC at the moment, which are offsetting overspend areas. And as highlighted, that is not going to continue. But what I can say is at the moment, if that will be covered by the allocation we get, I will have to update you once we know that detail. I'll stop at that point, Chair.
Many thanks. Given the degree of uncertainty, obviously there are many things you can't answer at this point. Any questions for Stuart or comments on the financial position at the moment? Okay, and appreciate your comment that you made earlier that this is now very much becoming about system finance balance, that it is important to understand the situation for the CCG, but actually the situation of the wider system is equally, if not more important, as we move forwards. Toby.
Thank you, Jo. I think I've got the mute right this time around. Just to build on Stuart's description about the financial uncertainty at the moment and the ambiguity and the pace with which things are moving, in those kind of situations, confidence, particularly from our regulators, in our own strength and capability in financial management becomes more important than ever. And I mentioned earlier on the regional leadership team meeting that I was part of yesterday, where the regional finance director, Mark Mansfield, updated on a number of areas and aspects of things. And without going into inappropriate levels of detail on a public forum to that, just wanted to reassure the board that clearly from the information shared yesterday, there are a number of patches, including CCG areas across the Midlands, where there are very different conversations and pieces of work underway at the moment, looking at local positions. And I think the way that Stuart in particular and the team from a financial perspective are running things and holding things from a CCG point of view locally is something that we should take assurance that we're not part of that equivalent set of conversations. And there's one thing that kind of is a sort of certainty in these sorts of roles, which is the more that we can retain our kind of license to operate because of the way that we run and manage things ourselves, notwithstanding all the moving parts to all of this, then the more freedom that gives us to get on and focus on doing the right things that we need to do locally, rather than needing to play further into some of those external arrangements. So I just wanted that to be acknowledged, and sorry some of that's a bit cryptic. I can't put names or numbers to some of those things for reasons you'll all understand, but I just wanted to be board to be cited that in what is a fairly swirling environment at the moment, I think we still should recognise that we have a very strong, stable team that gives us some anchor in all of that. Thank you.
Thank you, and very much recognise the efforts by our team as well. Any other comments or questions with regard to the finance paper? Okay, thank you. So I'm going to move on to the next item on the agenda, which is the Contracting and Procurement Joint Highlight report. This is over to you, Sarah. What would you like to tell us?
Thank you, Chair. Briefly, I'll take the paper as read. There isn't a huge amount that has changed that you haven't already been briefed on by either Stuart or as part of the phase 3 letter. So we continue to see activity underperform against its pre-COVID contract baseline, if you like, and that we would all be expecting. And the phase 3 letter targets some significant change in terms of that activity profile. The contracts portfolio, as Stuart's described, for our NHS contracts will continue to be as is until the end of September. And we await what arrangements look like after that. But we do know now explicitly that written contracts will not be required with our NHS providers for the rest of 2021. So we know that. Other than that, from a contracts point of view, Joe, I think there's nothing in the paper that is of note for governing body other than those new arrangements. And then from a procurement point of view, I think the thing I would just draw colleagues' attention to is our proposal around the procurement pipeline. So governing body doesn't need me to tell you that there have been some issues in terms of contract renewals, extension and the procurement pipeline over the past period. And so I've been working quite hard with the procurement team to develop both a dashboard and a pipeline and a method of proactively addressing some of that, which should start to hit committees from next month. And therefore, I would hope that over the next 2 to 3 months, we start to see much less of some of the activity from previously and much more of some proactive decisions around procurement. To manage expectations, that may be that we still look to extend various contracts, but hopefully we look to do that in time, proactively for the right reasons rather than reactively. And they're the things that I pull out of the paper. I'm happy to take any questions.
Thank you. Andrew and then David.
Hi, it's just a quick one that got me thinking, looking at the data on the non-NHS contracts. So, for example, the Corby Urgent Care Centre. So, noticing that we're sort of continuing with a block arrangement for the period of the first quarter, but obviously the activity is substantially down. Now, there's a question around how do we negotiate what are public funds going to a third party that aren't totally required. I understand they'll have infrastructure costs, but it leads me on to the question in terms of how do we forecast that level of activity? Because there's going to be risk for the supplier in terms of renegotiated position. There's going to be risk for the CCG. So it's just, I guess it's a question of how do we factor in this level of ambiguity whilst maintaining the best value for money for the public money that's going into these third-party providers. It's a bit of an open question, but I think we ought to be thinking about that sort of thing.
I think, Andrew, I think it's a great question. And I think one of the things that hopefully the really focused work over the next 2 to 4 weeks will do for us is to get us a robust estimate and set of assumptions as to how we forecast activity for the rest of the year for the system. We are working really hard as a kind of analytics and performance community as to how we do that forecasting. And hopefully once we've done that as part of the planning process, that will enable us proactively to have some of those conversations.
Thank you, that's really helpful. Philip.
Very similar question to Andrew, actually, and that is, going forward, the next phase, when I read it, appeared to involve the treatment centres both for treatment options for patients and also for increased diagnostics. And just wondering how those services are going to be advertised so that our patients can access those, and also what the implications are for contracting and obviously financial implications.
Sarah, do you want to answer that one?
I can. I'm not sure I can give a complete answer to that question, Jo, but I can give a level of assurance. We're currently working through, Philip, a number of the implications from a service delivery point of view. And again, as part of the planning process, I would expect that to become clearer over the next kind of 2 to 3 weeks. And we will have to, for those non-NHS contracts, and to be fair, even for NHS contracts, reach an understanding with service providers in terms of the implications for that. We have not done so yet, and we're working through what that means with most of the providers in the portfolio. So it's a work, honestly, at this point in time, it's still a work in progress, but it is in progress.
Thank you. Apologies, I missed David. I'll have to grovel in your general direction. Please do comment.
No problem. Yeah, I'm coming back to something I said about commissioning before when this has come up. In a way, one of the most important things from the public's perspective that the CCG does is shape the nature of health services in the county by commissioning, by deciding what to spend money on. The public is very aware of the financial pressures on the health service and in some ways worried about what this might mean. So having a narrative about what is the direction, what is happening, is really important at the moment for continuing to sustain public trust. I'm not suggesting there is a lack of trust, far from it, but around commissioning we get into all the technicalities of all of this, but alongside that there needs to be a straightforward narrative. Are we going to be able to afford to keep the hospitals going? Is a very basic question which people are not desperately worried about, but are thinking about. What is going to be the consequences of COVID and so on? So when we're talking about commissioning, it would be really good to have on the website a simple, or not simple is the wrong word, but a general description of what is it that our intentions are about how we sustain the health service across this difficult time, and what does this commissioning report mean? So I'm not, sorry, my phone is going and somebody else will answer it. Penalties are working from home. But can we do something along those lines so that we're seen to be engaging with the community and meeting some of their anxieties? Because I think we've said we've got a good story to tell, but we need to get it in shape. Thank you, Jo.
Yeah, thank you. And certainly really happy to work with HealthWatch to understand the messages that are being heard by the public, which may not necessarily be exactly the same as the messages that we're putting out, in order to make sure that we get that narrative right, not just as a CCG, but also as a system, because I think it is really important that we communicate with our public as a system. I know that the joint comms team across the system has been working really hard, and a lot of these things are common worries to the population that we serve. So I would very much appreciate HealthWatch's feedback on that, and obviously that will help us to shape the narrative moving forward. So we would value your support with that. Thank you. Any other comments from anybody or questions with regard to the contracting and procurement report? Okay, so so that does not require any approval and is presented to us for assurance. So the next item on the agenda is the quality, safety and performance report. This is obviously a report again of 2 parts, the quality and safety first and then the performance afterwards. Ange, do you want to talk to us about the quality and safety element to start with, and say thank you for the summary?
Okay, thank you, Jo. I'll pull out some of the highlights first. So just to bring to people's attention, we've seen quite a dramatic increase in the amount of patients with mental health accessing services. So we've seen a real increase, and that's been noted as an issue, especially through A&E. So that's something as a system we're looking at, working very closely with NHFT, also our colleagues in the council as well, to see if that's linked up. And we have escalated this to NHS England and they're aware of it. They've seen also quite an increase in the Midlands region as well. And obviously there's been quite an issue around beds as well. So when patients are presenting, they're presenting with quite acuity. That's increased. So that's been noted, and probably over the lockdown period, they've not been accessing services. So it really has been noted over the last month or so. I've already spoken briefly about St Andrews, but just to bring you up to speed, that we're meeting with them regularly over quality as well as IPC. We've seen a real improvement around IPC, and I've said they've haven't had a patient with COVID for 106 days, which has been really good for them in terms of adhering to their action plans. So we're keeping sighted on what's happening at St Andrews. We still have ongoing issues, but we work very closely with our colleagues in the council, especially around safeguarding. St Matthew's as well, we've been working closely with them, and I'm pleased to say that their COVID action plan has been implemented really well. So we're working closely with them. However, they were rated inadequate by CQC around care and quality in February. So we're working closely with CQC and with St Matthew's and ourselves, and also our colleagues in NAS. In terms of care home and dom care, we've been doing great stuff there. We've already alluded to it, and I know Toby's already talked about some of the stuff we're doing in his paper, but we've got the joint task force in place now that's been going out there doing reviews, which will help us in terms of clearing the backlogs in terms of phase 3, because we're doing joint assessments with our CHC colleagues in Arden and Gem, with our colleagues in NAS as well. And I'm really pleased to let you know that we're one of 2 pilot sites again in the Midlands region, and we're leading on the self-testing for visiting professionals into care homes. So it's live this week, so I think we'll probably go live tomorrow. So it's still very new, but I think that's going to have quite an impact in Northamptonshire, and obviously because we're a pilot, we'll be evaluated. And NHS England are looking at this information really closely in terms of rolling this out nationally. So I'll keep the governing body appraised of this on our next meeting. In terms of safeguarding, we have seen quite an increase in all levels of reviews. Some very sad situations, especially around domestic abuse. We've had quite a few child deaths. It's been quite a sad situation in terms of safeguarding, but just to assure you, as a system, we're working very closely with our partners, working closely with our adults board and our children's board, and as a system really pulling together on this, and working closely with our MASH as well, first point of contact. So in terms of safeguarding, it has been quite a challenging situation, but as a system we've pulled together as well as we can do to tackle some of these really difficult situations. Chair, if it's okay, I'll stop here. Do you want me to wait for questions, or should we have Sarah first and then we do it collectively?
I think it would be useful to have Sarah doing her part of it first, because we always said we should triangulate those 3 aspects, and then we'll open that up for questions. So Sarah, over to you for the performance element.
Thank you. So really only a couple of things to pull out of the report, which I will assume has been read. There are a number of obviously issues with performance which are all expected, and we are well briefed on and are managing. I think the thing to pull out is the now significant issue both across the county and with out of county providers with 52-week waits. So unvalidated data for June currently suggests that we have 257 patients waiting over 52 weeks. I'm going to stretch back in my memory, but I think last month that was 6 or 7. So we have a significant increase in the number of patients waiting for significant periods of time for treatment. We do have a process in place with our colleagues from Quality in terms of harm reviews for KGH and for NGH. But what I have had a conversation about in the past couple of weeks and have picked up with Ange and her team is how we assure ourselves of those processes for our out-of-county providers, because currently the majority of patients waiting over 52 weeks aren't with Northamptonshire providers. And therefore, I think we need probably to get a better handle and we might have had historically on harm reviews in terms of our out-of-county provision. So I'll look to bring something back with Ange next month in terms of how we're proposing to address that. But that's really the main thing, Joe, I think, to pull out of the performance report.
Thank you very much, and so I'm delighted again to see these things adjacent in the paper, because it is terribly important that we recognise the connection between these areas. Any comments or queries? Philip.
Just to say about the out-of-county providers, we are very aware of that, and Oxfordshire have refused to open up their outpatient appointments and have been sending patients back to us that we referred in March. I've not taken it up through the CCG because I know the Oxfordshire LMC have taken this up very actively, and local politicians and local representatives on the governing body of the hospitals have taken it up on our behalf. But just to let you know that we are aware of it, and the MPs are onto it. We just cannot believe the way that they are behaving, and we'll account for some of those long waits that we've got. And if you'd like more information from me, Sarah or Angie, please let me know. But it is being taken out of county.
I think it's a fair point, and I think it's been said before, we are a county with a lot of edges, and each of the edges of the county has its own peculiarities, particularly with adjacent lockdown zones and areas of high COVID, as well as some of the clinical activity as well. So I think it is important that we are mindful of the edges as well as the centre of the county as well. Chris, did you want to come in at this point?
Yeah, the question's for Sarah, actually. Given the 52-week waits started their patient journey last summer, and given the substantial increase in 1 month, are you expecting yet further increases on an exponential basis for the next 4 to 5 months before it starts to taper and then come down?
I think I can give you a gut instinct answer to that question, Chris, that isn't backed up by the data at the moment. But yes, I think given the pause in elective activity that we've seen, given the fact that we know that elective activity hasn't stepped back up to its pre-COVID level yet, I would expect that position to continue to deteriorate. I will be in a better position once we get through to the 21st of September in the planning round, when both of our local hospitals and the CCG have fully assessed their capacity and its impact on the proposed levels of activity, to give you a bit more detail about how long we expect that to continue and the potential material volumes involved. But yes, I think it is likely to worsen before it gets better. Yes.
Absolutely, and I think that's something that as clinical leaders across the system, we're very much sighted on collating clinical risks across the system, looking at where patients may come to harm, looking at appropriate mitigations, and I think it's something that affects patients who come into contact with a number of different providers, but it is a worrying situation from a potential clinical harm situation. Toby.
Thanks, Joe. So all of our comments are in the same territory here, because I was going to pick up the same point around elective, around RTT, and around delays and wait position. But building on what Chris was saying there, provisional information that was being shared yesterday through regional conversations, absolutely, Sarah, was consistent with what you've just described, unfortunately, which is seeing almost a near doubling in terms of the overall numbers for the month of July. And if you start to extrapolate that forward, you can see it building. I think the interesting thing for me, just looking at the comparative position, and this speaks to Philip's point across the region, clearly this is very differential, trust by trust, in terms of our acute providers, both in county and elsewhere. And I suspect in part, and this is just me kind of hypothesizing, that probably partly reflects people's experiences of COVID and of the last 4 months and the kind of pressures that's left in the system. But it will also, no doubt, as these things always do, reflect the leadership and management and approach that individual organisations choose to take. So really, that's my way of giving a sort of double support for what, Sarah, you've described doing with Angela, which is to pick up and look at this. And the more intelligence that you and others can feed back about experiences with our out-of-county acute providers as well, the more we can build that picture. So it isn't just the LMC in Oxfordshire and elsewhere that's picking that up, but we can get more active in that conversation as well. And I think that this should be and needs to be one of the benefits of some of those new regional forums, to allow others of us to be able to bring those kinds of issues into other county conversations that affect our patients as well locally. So I think we need to watch this really carefully. And I think actually next time round, Sarah and we could do with seeing something more detailed that breaks some of this down so we can see and understand, and then either be assured of the active management of that or escalate things further from governing body if we need to.
Philip, did you want to respond to that item, or is this a separate thing?
No, I just wanted to respond to what Toby said, which of course is the implication is if you've got ENT lists, outpatient appointments closed in one provider, it means that there's an increased demand on Northampton and Kettering, who have tried to play ball and open up their outpatient to a limited extent. But it's adding to the problems within the system, which is totally unfair when you've got a block contract and a trust being paid not to deliver. So if you like more, just drop me a line if you'd like more information about it. But I think it does have knock-on effect throughout the county.
And I think that sort of intelligence is really important. I think obviously all but one locality very much has a reach across county borders. I think even the Northampton one, that your patients do sometimes go out of county. So I think where that intelligence can be gathered from our localities, I think that's really important to feed that into our teams. Thank you. Ali.
Thanks, Chair. I agree with what's been said. I do want to take the conversation back to the Northamptonshire area, because the elective care collective work across providers and with primary care is still work in progress. So some of the solutions to this is that we all work together to make sure that we're reducing those weights within the control that we have. So there are only some system forums. We need to develop more of it. So I know part of this is as a consequence of COVID and the impact on capacity, but some of the solution to it is held within Northamptonshire as well as across the borders. And I think the outpatient conversations we're going to be having later might bring some of that context in. So Sarah, I'll connect in with you so that we bring that whole system transformational approach to the solution into it from an elective care portfolio perspective.
Thank you, that's helpful. Any other comments on any aspects of quality, safety or performance? Okay, thank you. Thank you for that rich conversation. I think it's really important that we've heard the patient's voice within this. We do understand their distress, and certainly those of us that are working frontline very much feel what people are going through. We understand people's anxieties and absolutely recognise the mental health impact as well on our population, as well as the physical care as well. So it continues to be of concern to us as a governing body. The next item on the agenda is Ange's 15 and his modern slavery and human trafficking statement. This is an item for approval. It is one of these items that we see regularly, unfortunately. Equally important. Ange, is there anything you want to draw our attention to with this paper?
No, just to say, obviously we refresh it every year. It sits on our website. It's something that we do because it's the right thing to do, but we must do it in terms of the Modern Slavery Act 2015. It covers the key sections you would expect it to see around sexual exploitation, around making sure that when you recruit in people who are entitled and are not being pressed to work. So it's best practice, Joe. It's something we must do. There's nothing there that I think people will see and not be familiar with. But it's here for approval because it needs to be refreshed and to go back onto the website. So really it's saying what it needs to say, Joe. So I'll take any questions, but really it's a refresh that we do each year.
And as with many aspects of safeguarding, it is something we approve here, but it's also everybody's responsibility to be vigilant and report, and wherever people are concerned, to understand what the processes are for doing that. Any questions on this item? So if everybody is happy, if you would like to type the word approve in the chat bar, that would be really helpful. Thank you. Thank you. We have enough. If you wish to keep putting, that's fine, but we have enough to be quiet from that point of view. So the final key item on the agenda is the primary care report. Julie has kindly come to talk to us about that. This is obviously a paper with a huge amount of detail within it. Clearly lots of work going on. Julie, what would you like to draw our attention to particularly?
Thank you, Chair, and good afternoon, everyone. In terms of, I will take the paper as read. I think there have been other items that we've already discussed in terms of the phase 3 letter. So if I just can give you a quick update, we still have our primary care cell that meets on a weekly basis, and we took that the paper to them today in terms of the key outlines and actions that obviously we are going to have to do within primary care, so that they are cited, but noted that, you know, as Joe's already said, we've got all key clinicians in each of the areas aligned to this and working to that to support, and we'll be working with them going forward. The other update, just to make you aware, is in relation to the primary care networks and the alignment of the care homes. As you'll be aware, that there is a target date for us all to reach, but just in terms of an update, pleased to advise that we now have 92% of our homes that are linked to our primary care network, which is different to what it says in the paper. Of 210 homes, we have 209 that are aligned, one that is not aligned to a PCN, and further work is being undertaken at that. But in terms of our overall response, that means that we have 100% of our homes aligned, because obviously the remaining homes are linked to smaller LD homes, but obviously contact has been made. And then just to note that thanks to all the hard work of our member practices who have continued to obviously work to make this change and to help us to hit that target. And that is the update from primary care.
Excuse me, slight issues in the mute button. So thank you very much for that update, much appreciated. So I've got a question from Ange.
It's just Julie won't be aware of this yet. I've only just been informed, but the general practice 10-point plan has just been dropped into my email. They're starting to do the work again, which is really good. It's very timely, and I think our funding allocation might be 20k to support this, but it's only just come into my inbox, Julie, but that'll be really important. And I've got one of my colleagues, Tina Swain, pushing on that now so that we can support primary care with our general practice workforce around, you know, obviously keeping people within practice, but also in terms of recruitment. So I'll share that as I get more information, but that was shared with me today, which is another good positive thing for primary care, Julie.
Thank you, Ange.
Thank you. Any other comments, recognising that obviously primary care activity has in many cases returned to pre-COVID activities, the massive adaptations that have taken place, and recognising all the hard work of our member practices within the localities out there, and very much wanted to thank them for everything that they're doing. Toby.
Thanks, Joe. I've got a comment, and I think David, looking at the chat, was looking to come in again as well, if that's possible in a moment. Julie, it was a question about the estate section within the paperwork, which we touched on this at our last governing body meeting in terms of that work being restarted and sort of put back in place again. Just wondered if you're in a position, and appreciate I'm asking this alongside all of the other pressures that I acknowledged earlier on, but have you got any sense in terms of the validation work on the data we were looking at before, and when we might get to a point of being able to share that kind of prioritisation piece that I know people like Naomi and Sanjay worked so closely with you and Julie Curtis on before we went into COVID? And I'm partly asking out of self-interest because next week I shall be doing a round of sessions with our localities meetings, and I'd be very surprised if I managed to make it through a sequence of those without this question being asked, rightly so, as part of that. Thank you.
Thanks, Toby. Yes, I know it is on the agenda for next week. It is something that we are putting back onto our work plan to have a look. But as you alluded to and everybody's alluded to today, we obviously, our priority at the moment is to get the response for the phase 3 letter. But once we've got that draft in, because we have got a number of staff off at the moment, we will then get to it. In terms of the locality boards, I can say that the action that we did agree was that we would share the population and in terms of development, so the sustainable urban extensions, we said that we would share that with a small narrative around what does that mean in terms and where are we, and that will be being shared with the localities. But yeah, message is that it is back on our work plan to try and do, and we hope to sort of like get that validation piece probably out sort of like early September.
Toby, yep.
If I may just to follow up, it's offer of support really, Julie. I think it would be helpful if we picked it up at CMT with you for a bit of a conversation about how can we support and get to that point, particularly in Julie C's absence at the moment. If we were to schedule that for the first of our corporate management team meetings once we get the other side of that 1st of September submission, I think that will be helpful. I'm really keen that in September we do get to the point of being able to put that information in. I know you want to as well, but it's important, and it was so well worked up before we got to that stage that I'm really keen to make sure we don't go any more further into September than we need to without being able to get that out in an appropriate way. Thanks, Joe.
Thank you. And obviously important in the context of PCNs, recruiting a number of additional staff, which is absolutely key to our wider primary care workforce, and supports a lot of the national direction of travel. David, you're on mute. There
Sorry,
you go.
I'd unmuted, and anyway, even the best broadcasters do it. On primary care, I know that we're beginning to think again about the engagement strategies and meetings are being planned and so on. It would be easy to charge ahead with all of this stuff with ignoring some of the issues that we were aware of before about PCNs and PPGs, the very, very variable performance of PPGs. Do they matter? Have they got any significance at all? And if they are important, then they need to somehow connect in with something and to operate effectively. So that's something that HealthWatch is certainly interested to explore. And if I may cheekily go back to an earlier item, I'm sorry I missed this, but picking up on the mental health trends, of course, one of the immediate things this week, which we're quite concerned about, is the mental health impact of all the exams fiasco. We can anticipate some of that, and it is by far from being finished. And HealthWatch has identified that the A-level algorithm is a really nice example of structural discrimination in action. It's very easy to ignore or not to understand what structural discrimination means. But here is a very, very good example of how good intentions, and let's be generous, good intentions about making something work led to creating a system which significantly discriminated against people who were already discriminated against, poorer children, children from Black and minority communities. All this is well documented. And actually, of course, as we know, it was identified earlier. So we're going to be putting out a press statement about that, linking it to Lucy's annual report and the evidence of inequalities within the county, and how these are sustained, and how the new unitaries and the new structures have got to face this differently, and learn from that experience. It isn't through ill intentions, but if you just do the same again, it will perpetuate inequalities. I'm referring back to the mental health point, but the substantive point here was linking to the primary care PPG structures and looking at how we can get a more effective way of working, getting the public voice. Thank you very much.
Thank you. Julie, did you want to comment on that, or is that something we're going to come back to in future reports? Probably future reports. Yeah. So I think that is work in progress. You're absolutely right, David, to recognise that there is a lot of work going on in that area, and absolutely engaging with our public, not just in this area, but really across all of the system developments, is something that's really important to us as a system. Thank you. Any other comments on primary care from anybody? Thank you. Oh, who's not on mute? Okay. Would you like to comment, Julie? Yep, you can comment. You're on mute. Nope, still can't hear you.
Sorry, I couldn't unmute for some reason. I was just apologising to you, Chair. No.
Okay, that's fine. No, that's fine. Thank you. So, from the point of view of the key points from the today's meeting, I think there were quite a lot of points. A short meeting with many things to discuss. As ever, I think we recognise the ongoing COVID incident response and the local focus. We note that the third phase letter sets out the acceleration of activity, preparation for winter, support for staff, work on prevention, health and the health inequalities, and the need for the system to balance financially, although the current allocations are uncertain. We note the pharmaceutical needs assessment, which are currently being undertaken. We look at the challenges of the increasing safeguarding concerns and the importance of partnership working within those, and also the increasing numbers of patients waiting long periods of time, both inside and outside Northamptonshire. And we need to make sure that we're aware of any risk of harm to those patients. And we note the alignment of the PCNs to the care homes and all the hard work being undertaken by member practices. Thank you very much, everybody, for your attention and for your etiquette. I will close the meeting at this point. So if you could stop recording, please, Sarah.